Good day, and welcome to today's webinar entitled Beyond Compliance, How Payors Can Lead the Shift to Value-Based Population Health. My name is Mark Haglund, and I'm Editor-in-Chief at Healthcare Innovation. Today's program is sponsored by AssureCare. Thanks so much to all our friends at AssureCare and to you in our audience for giving us your time and attention today. Before we get started, I have just a few housekeeping details to share with you. To submit a question, please use the Q&A box to the left of your video window at any time. You do not have to wait until the end of the program. For technical issues, please press F5 to refresh. If that doesn't work, you can submit a question with your issue through the Q&A panel. Finally, join our webinar conversation on X, formerly Twitter. You can tweet using the hashtag #HILiveWebinar. And now at this time, it's my pleasure to introduce our speaker for today's program, Dr. Yousuf Ahmad. Dr. Ahmad brings to AssureCare a distinct and diverse healthcare perspective. Dedicated to helping people, he spent over 25 years in healthcare, working as a leader in health insurance, physician group practices, and multi-hospital health systems. Prior to AssureCare, he served as the president and CEO of Mercy Health, the largest health system in the state of Ohio and one of the largest in the U.S. Under his leadership, Mercy Health was named a Truven Top 15 health system 2 years in a row. He led Mercy Health in the development and execution of the region's first and only accountable care organization, the advancement of its patient-centered medical home project, and population health management. He has a doctorate in public health from the University of Kentucky, a master's of health administration from Xavier University, and a master's in business administration from Eastern Kentucky University. It's so great to be with you today, Dr. Ahmad. Welcome.
Thank you, Mark. Thank you for having me.
Great to be with you today. So let's dive in. This is a really fascinating subject area, and it's one that I think a lot of people might be confused about or a little bit unaware of. So let's begin kind of at 40,000 feet up. From your perspective, what are the key differences between a compliance-driven health system and a value-based population health model?
Well, you're starting off with a very heavy question already, I see. Thank you for the question, Mark. It's an excellent question, and it's a kind of thought-provoking question because it mandates a cultural shift. You know, a compliance-driven health system is really designed to meet regulatory requirements, avoid penalties, ensure adherence to legal and policy standards. It prioritizes rule following and documentation to demonstrate compliance with, government or payer mandates. In a value-based system, the focus is really on improving health outcomes for a defined population, and outcomes include reducing cost, increasing access, enhancing patient engagement. We know from a public health perspective, the more engaged a consumer or a patient or a member is, the better their health outcomes are. Focus on care delivery is different between the two systems. In a compliance-based system, care is reactive, and it's focused on individual patient interactions as opposed to a value-based system where the care is more proactive and focused more on prevention. And we look at other aspects of the person's life, not just clinical care. And by other aspects, I mean, social determinants of health, which include race, ethnicity, language, because we know there's a high disparity in our country, unfortunately, from a health equity perspective. So race, ethnicity, language is one component. Socioeconomic status, your education level, household income, your zip code, believe it or not, is one of the highest predictors of a person surviving a heart attack. So a value-based system is more, proactive, preventive, looks at not just clinical factors, but social factors, environmental factors. I often kind of chuckle when in our mainstream delivery of care system, and a doctor is to say a Medicare consumer, well, Mrs. Smith, you should walk in your neighborhood. But he or she does not know that Mrs. Smith's neighborhood is unsafe.
Yeah.
Well, an unsafe neighborhood, as you know, Mark, is a social determinant of health.
Yeah.
You know, how you measure success into two different systems is different. Financial incentives are misaligned. In a compliance-based system, it's really a fee-for-service system. So for a person who ran medical groups or hospitals in a previous life, the more patients I saw, the more money my institution made.
Yeah.
You know, now there is an element of, I hope they get better. I'm providing evidence-based medicine and the right coordination, but really, at the end of the day, it's a volume-based driven system, it's not value-based driven system. Yeah. And in a value-based driven system, you know, things like hospital readmissions are penalized, rightfully so. We have bundled payments taking place now, where if somebody's having a hip surgery, from pre-op to the surgery to the therapy to the imaging is all one payment. And I believe you've not asked me to take sides, but I believe as a student of public health, a value-based system is proving to be a much, much better system because of the measures I mentioned, outcomes, engagement, and enhancement.
Yeah. It's also a much more holistic system.
100%. Because even how you approach risk management, is different. And a value-based system empowers providers, including hospitals, to take risk in a very measured, mitigated manner.
Yeah. And we're already learning a lot. The shift into value-based care delivery and payment has not been even. It's been very uneven in the healthcare system, but it's not new. And we've learned a lot. And I know that payers have learned a lot from their interactions with providers. And per that, Dr. Ahmad, how can payers effectively incentivize providers to move beyond fee-for-service and embrace value-based care models? And I know I'm going to have a follow-up on that because it's a complex, layered question, right? But go ahead and tell me how you think that payers can incentivize providers.
Well, I want to say, because I work with a lot of payers are already extremely motivated to incent providers. And it begins by aligning financial incentives. So you can't have a provider or a provider network that's motivated by a volume-based system, and you have a payer trying to incent. So the example of that hip surgery bundle payment is one example where there's aligned incentives where, we want to make sure surgery happens on time, the patient is discharged as fast as possible. Now, if there are complications, of course, that takes subsequent extended time. Evidence-based guidelines are being followed, payer policies being met. And I think more and more payers want the doctors to be the leader. There's this, valid to a certain extent fervor in our country that, the payer kind of decides the care. The payer is really ultimately kind of foots the bill, but they want to work with providers with financially aligned incentives and empower them, which kind of warrants, sharing of risk. And physicians in America are never trained to take risk. There's no medical school that teaches you how to take risk.
Yeah, no, it's I agree with you completely, and it's fascinating because the best experiments or the best models, the models I've been proven most successful have been very collaborative. I just reported on an agreement between the state of Delaware and Nemours Children's Health. They're entering the first risk-based model for pediatric care across the health system with a state government. And that to me signals that we're moving into a more mature phase of the development of value-based alternative models.
Yes, and I think it warrants, data sharing. I mean, for the most part, physicians and payers who are both information rich do not exchange information in real time. And that's why we end up practicing defensive medicine because if the doctor doesn't have something that's done by an MRI done by one doctor, and I need that MRI is still valid, I, as the new physician, different specialty, can use it. I don't have access to it.
So everything you said totally makes sense. And one of the things that we're realizing in this long journey is that data analytics and risk stratification will play an important role in successful value-based contracting. Share with us, if you would, your perspective on that role and what payers can do to promote and engage in the best data analytics and risk stratification in these contracts.
A great question. I believe payers are in a central position, in a salient position in leveraging analytics to promote a value-based care system that also inculcates risk-bearing agreements. And like I said before, they are information rich, but they also need to help the providers with, okay, how do I risk stratify a population? Let's just take a Medicare Advantage plan. And then how do I then tee up through my analytics to the provider after risk stratification is done, is which patients to focus on, who are the neediest of care, who have the most gaps in care. And then it needs to go a step further in the evolution of analytics as to what is the next best action that the provider has to take on those members, on those patients. And then analytics also measures the execution of the of the care plan. Did it work? Did it not work? How do we tweak it? How do we modify it? So it's a completely closed loop system if done right, starting with analytics, starting with identification of risk. So I think more and more you will see payers sharing data with providers, with provider networks, both partial risk, full risk contracts. You will see more and more. And I think as a country, we're moving towards, with an impetus of, hey, let's share more data, keeping HIPAA intact, keeping all the other security and privacy provisions intact.
Right. And part of the collaborative nature of that will be payers and providers working together to, as they say, marry claims and clinical data, correct?
And yeah, exactly right. And providers as a species are very data driven. These are scientists at heart. So, they are motivated by science, by numbers. And I have seen in my career, when you are transparent with them and show performance through objective measures, they want to improve. They want to improve, and they believe I've seen that a rising tide will lift all boats. As long as the process is transparent, fair, and in real time.
Yeah, very, very well said. Thank you. So, what are some of the potential barriers that payers face when working to implement value-based care models?
I think the first barrier I would say still is the reward system. Providers are rewarded overwhelmingly in America still on a volume-based system. Most providers in America are on an RVU-based compensation, relative value unit, which kind of measures complexity of care, length of care. So there's a fundamental shift that's required in terms of how we reimburse providers. We can't say, oh, we believe in value-based system, but the provider's paycheck is based on volume. So there's very strong dissonance when it comes to a reward system. So that has to be, I believe addressed first. There are data and technology challenges. I would say large health system employed providers are on a well-known electronic health record. They have a department or a division that produces reports and analytics. But half of America is still mom and pop physicians that does not have these robust infrastructure, and they're equally important in their communities as the care provider. So I think there will be some assistance needed in that area. Physicians, in my experience, for the most part, not to make a general statement, unless they're experienced with taking risk, they are risk averse. So that financial uncertainty, has to be addressed. So maybe the payer, instead of taking full risk with the provider or provider group, maybe they take partial risk, and they have pay for performance, where they're paying a little bit more based on quality metrics. Patient engagement is measured differently. The way a hospital measures patient engagement is different than a provider group, is kind of different than a payer. I'll give you one example that I've seen, and it brings the point home, Mark. This is a real life example. So there is a morbidly obese female patient who's also a smoker and just got pregnant. That consumer, that patient, traditionally would get 3 different campaigns. She would get a weight loss campaign, she would get a smoking cessation campaign, and she would get a prenatal campaign. But if you use analytics in the right way, you can do one campaign addressing 3 conditions. And that's a huge opportunity. And so providers love it, payers will love it. Ultimately, the consumer likes it, because they're like, hey, you actually know me now.
Yeah, absolutely. So let me also follow up. What role might public health organizations have in this, and how can payers work with public health?
It's a great question. As both a student of public health and a worker of public health, I think there has been a chasm between the two areas of payers and public health. And I think in my lifetime, the wake-up call was COVID, where these two areas, I would say industries, were not really talking and did not have the infrastructure to talk with one another. And I'm not sure we're any better today in that infrastructure development, but I believe there is some work happening. I mean, you see, we work with payers that are working with state government around disease registries, diabetes disease, asthma, a registry where they can share data as approved by law, including what treatments and therapies worked for a heart failure patient that also has diabetes. These two comorbidities are very common on a same patient. So I think we'll see more and more of that. Vaccine registries are, I believe, a huge opportunity for public-private partnership. And I think in many cases, you have these social determinants of health. Like, I often look at food insecurities, and it breaks my heart, Mark, because millions and millions of Americans don't get their SNAP benefits, their supplemental nutritional benefit, because they did not fill out the application right.
And as we know, the formula emerged several years ago that only 20% of a person's health is really connected to their interaction with the healthcare system. So the social determinants, of course, are incredibly important. And that leads to my next question, which is, how can payers support the development of truly integrated care teams on the provider side that focus on both clinical and social determinants of health in a value-based model?
I believe first of all, your statistic is absolutely correct that only 20% of health outcomes are associated with clinical work, and the overwhelming majority are social determinants of health. I believe that's where public health comes in, and really social health comes in. If I don't have a car to transport me to make my doctor's appointment, it doesn't matter. Nothing else will take place after that. And that's a very important kind of vehicle, pun intended, to get me transported. And payers you're seeing slowly, at least on the Medicaid side, where there is transportation as a covered benefit. And I believe you will see more and more as we shift towards value-based care, where payers will inculcate in their infrastructure and apparatus of decision-making these social determinants of health. They will pair, and I'm seeing this with payers, where if English is not my first language, can my care coordinator be picked who can speak my language? We see this in the world of nutrition, where in the past, let's take multiple sclerosis, for example. It's mostly a Caucasian disease, but you have one or two drugs, Tisabri and Ocrevus, infusion drugs that treat MS. But other than that, the only other way to treat MS is a gluten-free diet. But you have to customize that gluten-free diet to somebody's ethnic cuisine for them to be compliant. And you'll see more and more these retail grocers who have a bent on improving care. You'll see payers, to your point, improving their requirements and making sure they mandate, and that I think will be an inflection point, and it's coming.
Yeah, and I think that patient-facing, consumer-facing apps will play a role in that too, connecting all the stakeholders. So let me just ask a final question. What do you see as the financial implications for payers when shifting from a volume-based to a value-based care delivery and payment system, and how can they ensure sustainability and success in that transition?
I think there will be some risk involved for sure. I mean, you have the payer industry that's built over 100 years with a certain amount of actuarial science, with a certain amount of tricks and trade of how to take risk. Our government has gotten better in making sure majority of the MLR, the medical loss ratio, is focused towards payers are focused towards patient care. I think it's going to require addressing change incrementally. I don't think most payers will just one day say, we're changing our model. So I think managing that sort of risk is important, in that change. Like I said, aligning incentives with providers is important. Sharing data is important. You brought up an excellent point, Mark, which is music to my ears, that how do you bring in, social determinants of health that bridge the chasm between public health and private health, but also ultimately addresses racial disparities, in healthcare. I mean, there are studies after studies where you have African-American population, children being born in the backyards of children's hospitals in America with very high infant mortality rate. Yeah. Because I think that doesn't mean our children's hospital in America do a great job, but that data is missing. That intentionality has to be there. And this is coming from a student of public health, where I see the data, I research it, I review it, and I think data will become the new oil if it hasn't already. It's a huge asset that has to be mined, that has to be stratified, that has to be provisioned to the care provider at the right time for the ultimate well-being of the consumer.
Yeah, and data will absolutely be the currency of improvement of care delivery. Any final thoughts before we conclude, Dr. Ahmad?
I think there is a level of frustration that I see in the consumers of the country. What gives me hope is I see a lot of innovation from payers and providers that to a certain extent will address that frustration. I believe there's a lot of defensive medicine we practice in America because of the way health system has been created. I think slowly but surely that is being addressed. I think the more transparent we are with our information, including with the consumer, the higher the trust ratio goes up with them. And I think collaboration, care coordination collaboration will be the fulcrum in making, think about it. Your average Medicare consumer is on 8 different medications provided by 6 different providers who, even if they work for the same health system, are not coordinated. So there's a huge opportunity,
Exactly.
and I think I'm more of the glass half full kind of guy. I think we will get there and get there soon. We have to.
Yeah, absolutely. Well, thank you so much for this wonderful discussion, Dr. Ahmad. I think you've enlightened us a great deal, and these are information and insights that we all needed. So thank you so much.
Thank you for having me, and thanks to your audience.
Thank you. This concludes this session. Thank you, everyone.